Hello, hello. Hey, Chris, how are you? Long time no see. I think it's been like 12 hours.
I know. I was like, we literally were just here yesterday for the conference wrap up. If anybody didn't watch it, watch it. It was so good to go over our conference experience because it still feels surreal that it's over. I'm so sad.
I know. I'm like sad that it's over, but I'm also excited to be back here and back on these. So, hi everyone. I'm so happy to see y'all, and just a special thanks to Chris, who has been covering while I was out on maternity leave with a little newborn. So yeah, thank you, Chris. I know you have been amazing as you always are, and I'm just excited to be back here with you. I know we went yesterday and talked all about our I'm going to call it our lineup for the next couple months, and it's just so exciting. I loved that. I feel like one of the things we did that y'all may or may not know that we do is we spend a lot of time every week of like, what are we hearing people want more of? What do we think got the best responses at the conference? And that's how we tailor our content. Try to get y'all some light in here, to some content to best hopefully help y'all. And so the reason I say it is, most importantly, please go to iocdf.org/peace of mind, because we want to hear from you of what you guys want. So we try our best to cover the things that we think we're hearing and that makes sense, but we want to know if you're like, hey, I need you to cover trichotillomania, and like you guys aren't doing a great job with that, tell us so that we can make sure we're covering the content that's most important to you. But just so excited to be here, and I feel like the conference gave us this new energy and excitement. It allowed us to hear a lot from folks individually, and I just want to start by saying thank you to this community. And I know, Chris, I'll give you the floor, but Chris and I both kind of talked about how surreal it was to meet so many of you in person, and also to just get to hear from you that this live stream really does impact a lot of you and allows you to seek support or encourage you to come to the conference. And I know for myself, and I can speak for Chris, like that's why we do this. And so just thank y'all. Thank you for being such a great and awesome community.
Yeah, no, I just want to second that. It was amazing at the conference. So many people came up to Liz and I and were just saying, hey, we watch your live streams. We really enjoy them. They've been super helpful to get me in between sessions, or I'm on a wait list right now and it's been like my community, or, hey, during the pandemic when I was isolated, I would log in and watch you both. So it was super honored. Like I felt so honored just to have people come up to us and say like, hey, I watch your live streams. It was surreal. So thank you so much. It means the world to us because we enjoy doing this, and to hear back that you both enjoy it. And it was funny because I think people always assume we're together because they would see me and they'd be like, hi, hey, where's Liz? And I was like,
we're not always attached at the hip, but we would love to be.
I know. But you need to come to California because we have better weather. But
Yes, you do not want to come to Houston in July. I can promise you that. So,
no.
Well, so excited to have y'all back. Let's hop in. A couple important announcements, as always. This is not intended to replace therapy. These live streams are intended to be educational, and Chris and I do our best to share personal and professional examples or feedback. But of course, we are not your individual clinician, and we encourage you to be working with one to get any feedback about your specific diagnosis or symptoms that you're struggling with. Of course, the IOCDF is not a crisis hotline. If you're in crisis, if you're feeling suicidal or unsafe, please go to your local emergency room, call 911, or call the suicide prevention line at 1-800-273-8255 here in the US. Of course, if you're international, please follow your guidelines. We always ask that we create a safe space. So in the comment section, please use that to talk to each other, to encourage each other, to build your community, to also ask questions to Chris and I. However, also please keep it positive and supportive. At the end of the day, that's important to us. And I always want to throw in, I haven't talked about this in a while, that I steer away from us answering any medication questions. And I also would encourage you to do the same in the chat, to really not share specifics around dosage and medication, because that really should be done with a psychiatrist and under the care of a medical professional, not among each other. Lastly, next week, I am so excited. I'm going to make Chris join, and he's probably like, well, I'm going to join, and like it's perinatal. But I think it's important because, Chris, I actually was thinking about how critical it will be for you as a clinician who doesn't have a personal experience with perinatal, but who's going to certainly be treating at some point, or maybe even right now, perinatal patients, to kind of think about what are things you would want to know and that would be important. And so, sorry if you didn't want to do it.
No, I was open to it.
So next week, we are going to do a live stream focused on perinatal OCD. And perinatal OCD is the pregnancy and postpartum period. What's important to note that I want to say is it's not specific to women. So I think a lot of times we think, oh, the perinatal period only impacts women, but we actually see a lot of dads experience an increase in OCD and anxiety symptoms after the birth of a child as well. I can tell you that yesterday I told my husband that I was walking with our baby and I had hit her head a little bit and it scared her and she cried. And my husband told me this morning, oh, well, I stayed up last night Googling concussions to make sure she was fine. And I was like, what? Like, I didn't give her a concussion, right? But it was just evidence to me to remember that, like, dads experience anxiety too, and health anxiety. And like, there's different things with a new baby that gives them this new worry, new anxiety that may need to be addressed. So it's certainly not only for moms. But please join us. Both Dr. Elizabeth Netherton and Jessica Rohr, who focus on the perinatal period, anxiety, OCD, depression, will be joining us. So it will be a great live stream. But I'm happy, I guess, but I'm excited is what I actually meant to say, to hop in today. And Chris, I want you to take the floor if there's any announcements or things you want to talk about. But today's focus is going to be on us answering questions. We have a ton of pre-submitted, but then also any live questions. So any questions y'all have, please put them in the pane on the right-hand side of your screen so that we can answer them as we go. But then we also have probably a million that we could get to.
Yeah, we have a lot. No, my only announcements is I always say this is your live stream. Like, this really came out of, we used to do weekly themes, and whenever Liz and I would do just a general Q&A, it would get the most traction. And so people just kind of messaged us and said, look, what we really just want is our questions answered. So this is your live stream. Even if you don't have a question, please stick with us for the hour. I'm sure there's going to be a question answered that impacts you. But no, just excited to jump back in.
All right, so let's go. And I'm going to get up in a second and walk away for like 10 seconds to get my ring light because it's really dark and you guys can't totally see me, but I'm going to wait till Chris is answering a question, but I'm not leaving y'all. So let's start with the question actually today at 11:58, Skyla. And Skyla's on the back end. Thank you, Skyla. IOCDF is always running these live streams on the back. You guys don't see them, but they're there. So thank you for that. From Baden. So the thought, what if my loved ones confront some fatal fate as a punishment of my religiously wrong acts is harshly terrifying me? I think I wouldn't forgive myself and survive further. So what it sounds like I'm hearing you ask is, what if I do something wrong and then something really terrible happens to someone I love? And the next question that from the same individual that goes hand in hand is, please suggest how to get out of this terrifying uncertainty. So Chris, I'll let you take it away and then I'll hop in.
Yeah, no, I mean, I would say first and foremost, there we go. I would say first and foremost, it's like a lot of times what I notice with individuals with OCD is like, we get a thought, we get a feeling, and then we just automatically take that as truth. And the problem there is, you know, we will have this initial thought, right? Like around your faith, what if I do something wrong and I have this horrible punishment, which is not even for me, it's for my family. And that's how OCD gets you, right? Like, I think some of us could handle the uncertainty, the doubt that maybe something will happen to me, but it's going to attack your family, of course, because then it's like, oh, now you have this extra level of responsibility. So the bottom line is like, you know, how did you even come to this conclusion in the first place that suddenly like you are responsible? And when I go over with clients in the psychoeducation part, one of the kind of cognitive distortions that we see specifically in OCD is this hyper responsibility. And OCD is at it again for you. It's hyper responsibility here, where you have to live your like perfect life that is moral and religious, you know, purity and perfection, or else your family is going to be up, you know, for punishment. And so the problem is you're misreading these, you know, intrusive thoughts, these, you know, these intrusive feelings, and you're treating that as fact and you're just going for it. And then what's so insidious about OCD is like, once we start that compulsive process, it ignites the OCD cycle, and next thing you know, it's no longer feeling like OCD, it's just feeling like you and faith. And so that's, I think, the saddest part of scrupulosity, is that it takes people actually away from your faith, and it actually has it more lying in that uncertainty, that doubt, that fear, that anxiety, that angst, that distress. And so what we have to do here is we have to recognize that the compulsions is the only reason you're tied up into this story in your head. And what we need to do is start to reduce and then eliminate the compulsions. Now, you do it with a clinician on a hierarchy level, and you do it at a pace that isn't overwhelming to you. And what you'll start to notice is that the anxiety is really what's keeping you trapped, because I'm guessing like in your religion, they're not telling you like you have to be pure to the day you die or your family will be punished. It's those compulsions that make it feel real. And so I think we forget that we're the ones keeping it going. We're the ones that are giving the fuel to the car by doing the compulsion. So that would be the first point. I'll let Liz talk to the uncertainty component, but that's what I would start if you were my client, is just saying like, look, like, let's understand the difference between OCD and, you know, and like your religion. I think I do that with all my clients with scrupulosity because I have enough background in religions, or obviously we can always consult with someone else. But the things I hear people do with scrupulosity, nobody else in their faith is doing it. It's their own separate set of rules. And that's how you know it's OCD.
Can we like sidebar for a second, Chris, if you're okay with it, and talk about
Yeah.
uncertainty?
Yeah, of course.
This is Chris and I had a long conversation last night actually about this, and I was just speaking with Callie Werner, who a lot of y'all know too, who does a lot of the anxiety in athletes, and Chris and Callie did a talk at the conference. I think did you talk or you just?
No, we're doing one in fall.
We're doing one in the fall, but y'all met for the first time.
I met for the first time. Yeah, so good to meet her.
Excited, so fun. And so we were just talking about the same thing. Is that I think lately uncertainty has gotten a bad rap in our field, and I want to talk a little bit about maybe why and help dispel some of those myths, because I think it's a really great question to say, like, how do I get out of this terrifying uncertainty? And the reason I want to bring it up is that those of us with OCD, right, Chris, myself, you guys, we have to lean into uncertainty because we have no other choice to get freedom from the fear. So when we talk about how do I get out of a fear, right, this crippling fear of uncertainty, it's actually by leaning in and accepting uncertainty. And what happens is when we quit trying to fight the uncertainty, so like, what happens, right? When we have an OCD trigger, OCD tells us we need to be certain. And so we start trying to get certainty. Well, certainty isn't feasible in life. And so we get stuck. And the more we try to get certainty through rituals or through, whether it's mental rituals, external compulsions, it doesn't really matter, the more stuck we get and the more OCD gets amplified, right? Because it has more power now because we're in the stuck. When the reality is that uncertainty is actually what we have to accept regardless. It doesn't matter how many rituals you do. It doesn't matter how much we feel like we're getting closer to certainty or we have a feeling that it's better. We haven't ever actually achieved certainty because it's not an achievable, tangible thing, right? You can't be totally certain. And so what happens is the way we get freedom from the fear of uncertainty is by accepting a level of uncertainty. And I know, right? Y'all know that's terrifying for those of us with OCD because it goes so far. It feels like it goes against our morals and our values and these things that are important, right? It's like, well, why would I want to accept uncertainty that something bad might happen to someone I love or to my family members, as you're asking, right? But the reality is that no matter how many rituals you do, you can't be certain that nothing isn't going to happen. And so you still have to accept a level of uncertainty regardless. And so when we talk about the importance of uncertainty in OCD treatment, that does not mean, and I brought up Callie's name because Chris, Callie, and I are going to do a talk on this in November. It does not mean that we have to accept our worst case scenario. Right? If I have a fear, if I have pedophilia OCD, I do not have to accept and be okay with being a pedophile. Because guess what? Like, I'm not going to do that. I'm not going to be okay with that. That goes against my values and who I am as a person. But do I have to accept the possibility that there is a degree of unknown that I can't necessarily know for 100% certainty that I'm not, right? Yes. And guess what? People without OCD accept that level of uncertainty every day of their life. They just don't know it, right? And so when we think about, I think a lot of people without OCD will say things like, well, why would we have to do uncertainty? Why do you need to lean into that? Those of us without OCD don't do that. And so why are you making someone with OCD do it? That's just negative. And because we don't have a choice. So when you're driving down the road and you have an intrusive thought of, you hit a bump and you have a thought, or you see a person and you have a thought of, I could swerve my car off the road and hit this person, right? People with OCD and without OCD have had weird thoughts like that. If you have a thought like that and you don't have OCD, you probably keep driving. And as you're driving, you start thinking about your to-do list and the things you have to do at work and what you have to do for the day or what you're going to do for the weekend. And by the time you get to the office and park your car, you forget you even had that thought, right? You don't even remember that you had the thought that you could swerve off the road and hurt someone. But someone with OCD, when they have that thought, it isn't just or if they've hit and run OCD, it isn't just a thought, it's a trigger. And so automatically that thought has so much weight, so much anxiety, so much distress accompanied with it that we start doing things that actually make that thought bigger, right? So maybe I start checking the rearview mirror. Maybe I turn the car around to make sure I didn't hit someone. Maybe I look in the rearview mirror to make sure I don't see other cars stopping or going to the aid of a person. And maybe by the time I get to my or when I get to the office, maybe I check my car to make sure there's not any marks or it doesn't look like I hit somebody. And what happens when we get to the office? That thought of whether we hit someone or not, that trigger, is the only thing we can think about. It's the only thing in our mind. And it's going to haunt us for the rest of the day if we continue to do rituals around it. But if we actually lean into the uncertainty of like, oh, like, I don't know for sure if I hit someone or not, and I'm going to move on with my day, that thought doesn't have power anymore because we haven't tried to answer it. The more we get stuck trying to solve, trying to answer, trying to figure it out, the more confused and stuck we get. And so you might say, well, that seems really crazy that we have to lean into that. And I agree, right? It's hard and I wish we didn't, but it works. It gives you freedom. But what I would also say, Chris, tell me if you disagree, is that person without OCD actually accepts the same thing we're asking you to accept. They just don't have to overtly do it because they do it automatically, right? They automatically, by not giving that thought power and by starting to think through their to-do list and everything else, they are accepting the uncertainty, right? They don't know for sure that they didn't do something wrong. They can't, there's not 100% certainty that nothing bad happened, right? They're accepting the uncertainty on their own. But those of us with OCD, we have to kind of go to these bigger degrees of acknowledging the uncertainty, because if we don't, OCD has us on a path of trying to find certainty where we get really stuck. Does that make sense, Chris? And do you have anything to add?
Yeah, the only thing I'll add, because I felt like you handled the uncertainty part, is the acceptance part. I think a lot of times people get stuck on that word. And if people are really stuck on the word, then I kind of throw in words like tolerate. But the way that I think of acceptance is I think people think acceptance is something you're doing, and acceptance is actually something you're choosing not to do. So for instance, like a big OCD trigger for me was like if I was to drive by a house being tented and it had termites and I was afraid of getting cancer. Acceptance, driving by it, the acceptance was not that I now need to do something, right? It was simply like, okay, I recognize that nobody else is driving by and freaking out because there's a house being tented. The neighbors haven't moved away. Like this is all kind of in my head. So acceptance is choosing not to put energy forth. I notice the house, I acknowledge it, and I continue to drive and go about my day. That's what acceptance really is. What isn't acceptance is me pulling over, or what I would have done is driven like a whole other direction out. I would have raced home, showered, washed my car, vacuumed my car. I would have gone online and searched. That's not acceptance. That's literally trying to solve something. And the problem with our disorders, we'll never solve it. If we magically do get some answer that we finally accept, OC is just going to skip to something else. And so, but Han, specifically with your subtype with scrupulosity, you have to be able to accept the unknown for the very fact that this isn't something that's Googleable. This isn't something you can go to a doctor. And look, I have clients that run to their priests, their pastors, the Pope. I had a client even like send something to Vatican City. It's like, even those answers are never good enough. And so if you choose to live your whole life trying to be certain that you're not going to send your family to a bad place because of what you did, there's not an end date to that. There's not a day you're just going to wake up and get that answer. And what's going to unfortunately happen is your whole life is going to plagued by this disorder. I think then people think that they're being irresponsible if they walk away from the compulsions. It's like, no, the compulsions is what's bringing on so much like confusion. Compulsions equal confusion, right? Doubt, uncertainty. That's what's causing it. When we stop the compulsions, our brains calm down, and then we're actually able to have like natural logic and rationale pop in and realize, wait a second, no, I don't need to do this. My family's not asking me to do it. My faith's not asking me to do it. My disorder is asking me to do it. And my disorder lies, and I'm not going to listen to it. So I know it can sound scary when we hear it, but to me, it actually is powerful. By accepting uncertainty, we're saying, I don't want to give this attention anymore because the attention I'm giving it is actually causing it to get louder. And when I walk away from it, I'm not walking away because I don't care about my family. I'm walking away because I no longer want to engage with this disorder that's not helping me do anything.
That's right. And can we talk for a second about the critical piece you just mentioned, Chris, of acceptance versus avoidance? And I want to talk for a second about how important it is for us to do exactly what Chris is saying. And here's what I want to say. Two things. Number one, the more you do this, if you have hit and run OCD, you will be able to respond just like that person who doesn't have OCD, right? So we don't have to lean into uncertainty in our worst case scenarios forever, because once we've addressed it, there is no longer a fear. And so what will happen is that when you're driving down the road and you have that thought, it stays a thought and you're able to move forward, and it's not a trigger. But when it's a trigger, we do have to approach it, right? We cannot avoid. And so what Chris is talking about is when we talk about accepting uncertainty, it doesn't mean necessarily this huge script and this negative sign and like going down these worst case scenario paths. It just means that like we're not going to avoid, and we're going to take risks that everyone else takes. But for us, it might have to be a little bit, it's going to feel more in our face, right? Because of course it's anxiety provoking, but the more we do it, the more it becomes a normal activity or a thought versus a trigger. And that's our goal. Our goal is how can thoughts stay thoughts versus be triggers? The only way is if you approach your fear. If you suppress your fear, it will keep chasing you. It'll keep coming up, right? So here's an example. I've had some people say things to me in treatment like, well, Liz, I keep doing exposures, but like it's still triggering me. And like it's still, when it pops up, I'm just really triggered by it. And my response is like, well, then we haven't gotten to the core, right? Because if we're doing ERP and we're addressing the core, it shouldn't remain a trigger. Because when you actually address the core, you will get freedom from it. Your insight will start to increase, right? I think a lot of people think, oh, don't expect freedom, don't expect relief. You will eventually get freedom and relief, and we want you to be shooting for that. It doesn't mean you shouldn't expect it immediately, right? Because that tends to be a ritual, is like I immediately washed my hands to feel better, but you will have long-term relief and you will have freedom. And Chris, I live in the Heights, so it's a lot of old bungalows. So there's a million tinted houses. There's one, close to us and always has been in different places. But I bet now you can drive past those and you don't feel the sense of anxiety. You don't feel the sense of overwhelming. And you might actually like be able to smile and be proud of yourself when you drive past them, because it's like, oh yeah, like that. Wow, that used to be a huge trigger. And now it's just a tinted house that looks like a carnival.
Well, yeah, the thing is, and the way that OCD worked is if a house was tented, I could never step foot in it. It wasn't even like that tenting process. So my mom had to get her house tented. And so if I ever had to go to my mom's house during treatment, I would sit in the backyard and then I would do all my rituals afterwards when I got home. Now I'm at my mom's house all the time. So it definitely, it goes back to lifestyle. Like being with my mom was more important than OCD. And that's what I wanted to add. Liz, you're saying everything I'd say, but I wanted to add too is like, the way that treatment should look is like re-emerging back into the person that you want to be. So for you, going back to you, Bethan, is that, I'm guessing two things are occurring because of this OCD. One, well, a couple more than just two, but the main things is you're probably not as close with faith anymore, because that's not faith. We don't go to church to be scolded and you have to do this or your family's going to go to hell. So, now your faith has been compromised. It's OCD relationship, not really with God. And then the second thing is I'm sure your family relationship is strained, because I know when I had guilt around having to do magical thinking to save my mom, I felt exasperation around her because I was so protective, because the OCD was like, you got to keep her alive. So now your family relationships are strained. And then lastly, your life. I mean, obviously going back to you, as your life is strained. And so I don't think of the treatment as this like fear factor punishing model. I actually think of it as an opportunity to get back into engaging in the things that matter, is to reignite with your faith, to reignite with your family, and to get back doing the things that you want to do. And so you have sort of like a fence in front of you, aka OCD, and the treatment is going to push you through. And so, it's going to be tempting. I don't know your ritual specifically, but let's say commonly it's over praying. It's going to be super, super tempting to pray after you're triggered from something. But if instead you say, look, I'm only praying, the only motive behind my praying is OCD. And I'm not trying to live an OCD life. I'm trying to live a fulfilled life. So I'm going to choose to maybe delay and eventually eliminate the praying simply because of OCD reasons. And I'm going to recognize that by doing that, just like with me, with being houses tented, the anxiety around it, the thoughts around it, and the fears around it dissipate. And then you can go into that house, or in your case, go to church.
Totally. Yeah, I love it. Sorry, we went on a tangent, but I think it's important, just because I think sometimes when people think of uncertainty, they think that like we would ask them to do something that we wouldn't do or that goes against your morals. And that's not what ERP is. ERP should not include if someone is asking you to do something that you're like, OCD or not, I would not do this. I want you to say, no, thank you. And like seek a second opinion, because that's not what treatment should be. I have 3 rules for exposures. It should be something, it should never be a surprise. We never throw an exposure on you, at you, make you do something you're not bought into and you don't agree with. It should always be something I'd be willing to do as the provider. And it should be something we are willing to do with you together. Right. And so if it's something that I'm like, oh, I would never do that, or like, oh, like I'm not doing that, we shouldn't be asking you to do it. Right. And so we're not asking you to do things that are dangerous, to do things that go against your morals or values. But we are going to ask you to do things that OCD perceives as risky or that goes against OCD, because again, OCD is wanting the impossible. It's wanting certainty, which is not achievable. Next question at 12:01, is there any known potential connection between OCD and sensory difficulties like SPD or misophonia? So absolutely. We definitely do see a lot of comorbidity with OCD, misophonia, but then also with sensory processing disorders. And there is a lot of education and treatment happening. I know there was some incredible talks at the conference. I wanted to say this past weekend, but I guess it was 2 weekends ago, where they did a lot of focus on OCD treatment and sensory, like both sensory integration, but also sensory difficulties. So there is connections. I believe we've done a live stream, I know, on misophonia. I believe we've also done one on sensory difficulties. But Skyla, let's please add this to our list of important topics for us to circle back to and share and think about doing another talk on this. Great question.
Quick, only thing I'll add is there's also comorbidity with autism as well. So that's something to check into.
Yes.
As well.
100%. Deepak at 12:06 p.m. I have pure O type. Sometimes I feel anxiety about things which are really important to me, like doubt and confusion and concepts in my studies. So I get confused whether to treat it as an obsession or not. Thoughts, Chris?
Yeah, I mean, I always think like, sometimes when I ask the client, I mean, I think as a clinician, my first step is always to discern between like, is this things that other people that are also in school kind of worry about, or is this obsessional to the point that it's really difficult for you to focus? You're in your head constantly. And so if you're noticing that's causing distress, and I always think of the best way to answer that question is the D in OCD stands for disorder. And what does disorder mean? It basically means that it's causing havoc on your personal life, your school life, your work life, etc. So if this isn't just kind of like normal, like test anxiety before an exam, or just a little nerves before the semester starts, but it's crippling and it's causing you to have really difficulties with school, etc., and you have OCD in general and you have other subtypes, it's probably OCD. So what do? The O is, I always tell people, like, the O is the original thought that OCD places. So let's say it's 8 a.m. and you have homework and you have studies and stuff at 8 a.m. that's the O, right? But if at 5 o'clock you are still in your head, you're still fixating, you're still ruminating on whatever that obsession was, that's no longer the O, that's morphed into the C, and now you're compulsively ruminating. And so what we have to do in this case is recognize, like, what are you hoping to achieve through the rumination? Typically when people tell me, I'm like, actually the rumination is causing the opposite of that. So my clients that are perfectionists and have OCD around their studies and their education, typically the OCD is causing them to have a hard time focusing in class, difficulty getting started. There's a lot of procrastination. There's a lot of dropping classes, etc. So we know the OCD isn't going to make you be a better student or achieve. And so once again, what we have to recognize is like the presence of that original obsession. We don't need to just take it and treat it like it's a real thing. It's not coming from your professor. It's not coming from a superintendent. It's coming from a disorder. The disorder never helps. And so once again, working with a clinician, what you would recognize is what are the C's that you're doing, whether it's mental, whether it's avoidance, etc. And that's one of the keys to eliminating OCD, is to reduce and then eventually dissipate. And this was my OCD around school and perfectionism. And I realized that my perfectionism was actually making school 2 times harder. When I went to grad school without OCD really impacting school, it was 10 times easier, which is usually the opposite for grad school versus undergrad.
Can you talk for a second, Chris, about like pure O and how, like, why some people might kind of identify with pure O, but what treatment looks like for individuals with pure O, and just so that we can kind of make sure we understand that as a subtype, maybe as a subtype of OCD or...
Yeah, so pure O, I think what happens a lot when it comes to advocacy when it comes to stories on OCD and stuff, because media is a very visual art form and people want to show things on camera, things like checking, things like hand washing, etc. People can really showcase that on TV. And plus, there's less stigma around those subtypes to publicly talk about it. So I think for a lot of people who have OCD, much more intrusive thoughts, maybe it's around harm, maybe it's around sexual intrusive thoughts or other things, they don't always feel like they're getting representation. So for a lot of people, they don't even know they have OCD. If you ask the average person what OCD is, it's organization or cleanliness, right? So when the term Puro came out, I think a lot of people initially identified with it because it's like, yes, that's what I have. Like I have obsessions around harm and stuff, but I don't do compulsions. The thing is, there are compulsions happening. And I think clinically, that's what we always have to make sure, because when people don't think compulsions are involved, they might then think that the treatment's not going to work for them because the treatment is so heavy focusing on eliminating the C, the compulsions, and then the obsessions will start to dissipate on their own. So Puro is basically kind of like I think of it more as like a community term that people identify with, of basically saying like, hey, if you followed me around for a day, you'd rarely see me do something outward. But heck, if you could read my brain, there's a lot of somersaulting. So the O is obsessions. The C can be mental compulsions. That might be counting in your head, replacing a bad thought with a good thought, pushing a thought away, or the physical one that comes out a lot is avoidance. So not going to a party because you're afraid you might do something reckless. Sure, I might not observe that, but that's still a compulsion. So the O and the C is still there. It just may not be as overt.
Absolutely. I love it. Yeah, so important. Thank you for sharing that. And I love the thought of like Puro is more of a community term than like an OCD term or subtype term, because it is like there is still compulsions that happen, and it's important for us to think about that because we're going to treat it the same.
Yeah.
12:07 your time. Any advice on how to deal with false memory OCD? The uncertainty is killing me. I'm a very stubborn person, and this combined with OCD is making me dig more and more because I can't give up.
I'll let you take since I answered the last one, I'll let you take the
Okay.
main. But the one thing that I want to add, it was actually a conversation we had with Jeff Szymanski on Tuesday, is I think sometimes we think like, I'm a stubborn person. You might not be a stubborn person. I think OCD messes with our identity sometimes. Like I'm sure in other areas of your life, you're not stubborn. So I think a lot of times, like the reason it probably was triggering me reading that is as a kid, I got labeled like a problem child, a stubborn child, a difficult child. It wasn't that I was any of those things. It was just the OCD, and my brain would not let me give up. So the good news is once you get better, we have that ability with OCD to really put our resources, our focus, our mentality, and do amazing things. But unfortunately, because OCD is kidnapping you right now, all your focus and stuff is going to stuff that isn't helpful.
Totally right. It's what OCD does. It pulls you in. And so it's like, why can't I just let this go? And it's like, well, because it's not me, it's my OCD, right? And it's making me believe I don't have a choice and I can't. So I'm actually going to leave this short and simple, but we actually just did a live stream recently on false memory OCD. So I definitely want you to check that out. You can go to youtube.org/IOCDF to find our old live streams. You could put in the search bar false memory and should be able to find it. But we deal with it the same way we deal with other types of subtypes of OCD, right? It's about us not searching for answers, accepting uncertainty and moving on, right? So if I have a false memory about whether I did something wrong or whether something I said offended someone or not, right? The important piece number one is I don't want to avoid. So I don't want to avoid talking to that person or calling that friend or thinking about them, because if I think, oh, well, I just won't talk to them, because what if I try to call them and they don't answer, then I'm going to be more upset. So I'm just not going to call them at all. Well, I don't want to do that because that's avoidance, right? That still will make the situation of the false memory bigger or feel more real, because again, I'm still feeding into it in some way. I'm choosing to not engage in actions because of OCD versus engage in my values. And so what would I want to do? Well, I'd want to call that friend, but I'd want to make sure I'm not doing any sort of checking or ritualistic behaviors, right? So I don't want to bring up that past situation. I don't want to make sure I didn't say something offensive. And I want to just kind of be able to accept the uncertainty that, like, who knows whether or not they may have been a little offended by something I said or really offended. And I'm not going to try to solve it and figure it out. So the way we deal with false memory OCD is we try to not solve it. We let it be and we move forward. Remember, that's where OCD gets the most stuck, is OCD wants to know for sure. Right? I want to know for sure I'm not contaminated. I want to know for sure something bad isn't going to happen. I want to know for sure I'm doing right by God. I want to know for sure that I didn't do something wrong. And the reality is that you can't know for sure. You can't have 100% certainty. And so that's where this accepting of uncertainty comes in. So with false memory, if I was afraid that I offended Chris in my conversation last night, I want to still show up to this live stream. I want to still host it with him. And I'm not going to bring up the situation from last night. When I get off today, I'm going to intentionally not mentally review whether or not it seemed like Chris was the same with me, or whether he seemed a little upset, or whether his tone was a little bit different. And instead, because I don't want to just not ritualize, I also want to accept the fact that like I don't know if he's upset with me or not, and I'm not going to try to figure it out. Because once I allow that unknown to be what I'm accepting, I don't have this need, or OCD can't pull me to try to figure it out and to try to solve it. So again, the big piece here is, how do we not solve? Right. So as Chris mentioned, the acceptance piece is that like we're accepting the unknown by also moving on, living our life, living by our values, and not trying to solve. Solving gets us stuck. Compulsions make us more confused.
Absolutely.
Do you want to hop into the next question? I'm trying.
Yeah. So at 12:14, we have from Lynn. She asked, what's the difference between health anxiety and OCD health anxiety? And then she goes on to say that she's using avoidance to cope. So avoiding doctors, books, shows about illness. The fear is the doctor will diagnose a deadly illness. So the thing about this is there are like, I look at it as semantics, but for instance, like health anxiety is not in the DSM. Obviously, OCD is. What they call it in the DSM is illness anxiety disorder. So that's kind of like just more of the technical term. And specifically, typically the way that like clinicians see the difference is if you have like illness anxiety disorders, it's usually the fear that I currently have a disease, whereas OCD, it's more a fear of getting a disease. So for instance, mine was much more fear of getting a disease. I was constantly worried I was going to get a disease, whereas illness, anxiety disorders is going to be more so like, I have it right now. Doctor, why can't you find my illness? But what I personally say is the treatment is very similar. And it's both. I mean, I've had clients with both in the same support group, and they both have like connect with each other and absolutely are like, yes, we have the same thing. So I think I don't want the community to get worried about semantics. What I want us to focus more on is, what do you do about it? So once again, Liz was talking earlier about the detriment of avoidance. And the problem with avoidance is that basically when you avoid something, what you're teaching your rational mind is like, this is a dangerous thing. So we know doctors, we know books, and we know shows about illness are not dangerous. But because of your brain, I think of, learning, your brain has learned that these things are dangerous through the avoidance. And so OCD is black or white. These things aren't dangerous and they're not 100% safe. They're somewhere in between. So we don't want them to get a bad rap in your life, which the avoidance is calling it. Now, we don't want to go the other extreme, start going to doctor's appointments all the time like I did, or looking up stuff all the time like I did as well. So what I tell clients is, find a show you absolutely enjoy. It doesn't have to be like a torturous thing where you're avoiding it and you're like, dang, my therapist wants me to do exposures. But if you genuinely have always had an interest in the show like House or Grey's Anatomy, watch the show. Now, while you're watching, totally prepare for thoughts, feelings, sensations, fears to pop up. That's where the response prevention comes in. Your job is to watch the show, enjoy the show, to engage with the characters, get some popcorn, watch it with family, and then all the things OCD asks you to do afterwards, that's going to reinforce something was dangerous. Nothing was dangerous. You're on your comfortable couch watching a show, eating popcorn. Like, enjoy the show and don't try to connect the dots simply because you see illness on TV. But my hope is that you can stop avoiding it, because you don't want to live like that, or else 5, 10, 15, 20 years later, then you do need to go to the doctors for something, and it's going to be such a uncomfortable situation. So
Totally.
Those are things we can't avoid in life.
Yeah, no, it's 100% true, right? And remember, avoidance feeds OCD the same way a compulsion does. And so we've got to learn to live life, but it not be, I think sometimes, I know I used to actually sometimes justify avoidance of like, well, it would be a ritual. So I would say something like, well, getting blood work might be a ritual for me, when really it was like, no, like I need to get blood work and I haven't done it in 2 years because I'm too afraid of what I might have. And so getting it once is actually an exposure. Now getting blood work multiple times in a month or something like that, if it's not recommended by the doctor or required by the doctor, yes, that's a compulsion. Next question at 11:15, and I'll take this one, is, 12:15, Skylight. Can you expand on the perfection OCD type? I often struggle with doubts and fears of making a mistake, but I don't see discussions about this type. So, yeah, I didn't know that I don't know, Chris, if we've done a perfectionism talk, at least in a while. So this is definitely something to add, because we were just saying to our live streams, we're going to add some stuff focused on school in the fall when school starts back up. So we can definitely make sure we touch more specifically on perfectionism, OCD. But again, this is very similar to what Chris was talking about earlier, is there's a big difference in someone caring about engaging or producing quality work, and or being a good student, or something being important and valuable to you, right? Just like I might tell you, like, my faith is really important to me and it's a big part of my life, but that doesn't mean I want my OCD to control my faith, right? There's a difference of like me engaging in faith activities that are meaningful and valuable compared to engaging in faith activities to appease my OCD. And it's the same with perfectionism, right? And so when you think about perfectionism in the workplace, are you rereading emails multiple times before you hit send? Are assignments and projects taking you much longer than they should have because you're engaging in ritualistic behavior, or you're stuck trying to make sure it's totally perfect when, like Chris said, no matter how many times you do the extra work, it's not making the product better at that point. It's not actually useful. It's just for OCD. When you hear people say things like, oh, my OCD is really helpful to me, or my OCD really helps me, and I've caught a mistake before when I double check something. That's not OCD, right? A double check that's useful, a quick reread. Sometimes if I'm sending an email to the president of McLean versus to Chris, I might spend more time rereading that one email versus the other, and that's okay. That's not OCD. But if I'm spending multiple times rereading it, if at night I'm getting woken up with anxiety and I'm checking my sent inbox and rereading it again and making sure I didn't say something inappropriate and getting stuck, now we see where it's more OCD. So again, the difference I would say is, what is the function? If the function of any sort of behavior is that it's actually useful, and that like, oh, I do it once and it's a useful double check, or, before I hit submit on my tax return, I might glance over it to make sure I punched in the numbers correct. That might be appropriate, compared to I'm spending 2 hours mulling over it and making sure, and I throw my W-2 out, but then I go get it out of the trash and I double check it again and make sure that it lines up and that I didn't do something wrong, because I don't want to have committed fraud and then go to jail. It's like, now we can see where OCD would be taking over.
Well said.
So many great resources that Skyla's been posting about scrupulosity and our faith and OCD resource center, which is so awesome. And other people are talking a little bit about health anxiety. So Chris, this is for you at 1222. How do I stop letting my BDD make me believe that if I get better, I'm just ignoring the real problem, which is that I really am ugly? I'm really struggling, and your story is inspiring.
Well, first of all, Kylie, thank you. And second, what I would say with BDD specifically, what's different, how I see BDD different than OCD, is insight. And also a lot of the beliefs, a lot of the things that we're experiencing with BDD, it's very egocentric, just basically meaning like we believe our thoughts and our feelings. And I think the additional difficult component is when we look in mirrors and pictures, like we literally see those flaws. It's not like there's no flaw. And sometimes we think, we really believe it. So Kylie, your fears of treatment is something I hear all the time. What if I get so much better in BDD treatment, and then I don't even recognize, because of the treatment, that I really am ugly and I do have these flaws, but the treatment's so good I don't think that anymore, and then I lived my whole life, whereas if I just got that surgery, I would have lived a better life. Almost like these two paths of, if I'm irresponsible and get better and don't fix the problem, my appearance, maybe I won't realize until the day I die that my life wasn't that great, because I never fixed the real problem, which was ugliness. I would argue that something different happens in treatment. We actually get really, really good insight, and we get clarity. And I think one of the craziest things for me is looking back at old pictures and being like, I thought I had horrible acne scars here, or, oh my God, I swore I was bald in this picture and I'm not. So if anything, the treatment gives us clarity to see the world and to see ourselves in the world the same way everybody else does. So what I love about the treatment is a lot of times people are willing to put surgeries and other cosmetic treatments or camouflaging or whatever compulsions on hold during the treatment. And at the end, they look back and they're like, thank goodness, with my clarity and insight, I don't want to go back to that. I realized it wasn't really about my appearance. It was a mental disorder. And so my hope is that you don't let that fear be one of the barriers into treatment, that you work with a clinician that really understands BDD. And what I promise you, if you get good treatment and you do the work, is at the end, you'll have a completely different belief system about how you look, who you are, the importance of other things outside of appearance. And you won't believe that statement. That's a very pre-treatment statement. I promise that statement will handle itself after treatment.
Totally. Yeah. And I would say that I think individuals with OCD probably have similar fears that are a little bit different, right? But fears like, will what if you have me go to treatment and now I become less religious, right? Or I don't want to not care about these things that are important to me. And it's like, actually, you get to care more in a meaningful way versus in an OCD way. Next question at 1224 from Brittany. What advice would you give to someone who not only suffers from sexual intrusive thoughts, but physical sensations as well? Sometimes it's hard to accept the uncertainty where your mind and your body are working against you. And this is such a good question and so important and so common.
Yeah, I mean, what makes OCD additionally difficult, but besides just like thoughts and feelings, is sensations. And so when we have sexual orientation OCD and other different sexual intrusive thoughts, sometimes we can get sensations in our body, like our nipples, like our growing areas, our privates, and stuff like that. And a lot of times, what happens is people use that as the evidence to prove that you have an attraction. What I like to do with clients that have this subtype, not in a compulsive way, not in a reassurance way, but in that psychoeducation, like prior to even starting the ERP, is really educate yourself on that. There's a lot of good research, there's a lot of good information out there that explains that, just because we have a tingle somewhere on our body doesn't always equate with attraction. I mean, especially in females and males, like you can have a growing response, and only 10 or 20% of the time that's even associated with attraction. The other thing is what we focus on the most we experience. So clients with like health anxiety, for instance, OCD around health, if you're always focusing on your shoulder and the pain it is, you're going to feel that pain because it's all you're focusing on. So my clients with this subtype, if all day they're literally checking with their growing, focusing on sensations, it is inevitable that something's going to happen down there because you're paying so much attention to it. So what we have to do is we can't let our interpretation of those sensations then equal, like the equation can't be like growing sensation equals I am, yours is sexual intrusive thoughts. Let's say it's around, I don't know what it's specifically around, but let's say it's a family member, right? Like we can't let sexual intrusive sensations equal I'm in love with a family member. What happens for almost every client with this subtype, because this was my subtype as well, when I stopped fixating on my sensations, I stopped focusing on my bodily sensations. When I didn't really give it attention, it went away. So now I don't really have sexual like sensations anymore around things that I don't want to correlate with attraction. So remember that the attraction and sexual sensations don't equate each other.
And remember, you can actually focus on them and allow them to go away, right? So again, as Chris is saying, the more we kind of like avoid like, oh, like, I don't know if that's a feeling, let me ignore it and suppress it, let me try to do something else to distract myself, the more it will keep being there. And when it pops up, we'll be triggered by it, where we actually want to lean into it. I remember specifically when I used to have a lot of intrusive thoughts around what if I have an STD, what if something is wrong. I can remember when I would be in hot yoga, sometimes I would like just feel different sensations. Like, yeah, you're in hot yoga and the sensations were real, but immediately my mind went to like, oh, it's an STD, or there's something wrong with me, or something's going on. And the more I thought about that, right, the bigger it became amplified. And what I had to do to address it is like, yeah, I do feel a sensation and who knows what it's from. And I'm going to accept that, like, could be something weird, could not be, and whatever, I'm going to keep moving on. And then it wasn't this big thing, right? That I'm trying to like, I can't have a sensation, I can't have a feeling. It's actually like, let's just allow space for them and move on.
Exactly.
At 1227, Skyla, my self-esteem is so shattered. I'm so worried everyone's making fun of me in public. I've been homebound for nearly 3 months. How do I attempt to get back into doing things that I enjoy?
Yeah, so Kylie was talking earlier about BDD. I mean, part of the BDD treatment is re-engaging in life and to re-engaging with connections with people. And I think that we see it from such an appearance lens. Like if I go out in public, everybody is judging me because of my appearance. People are reacting because of my appearance. When in actuality, most people are just shopping, trying to get the hell out of the heat and then go home. So part of what I do with my clients is I'm lucky to be in a very populous area in the center. And what we'll do is we'll go out to the mall and we'll engage. And what happens is people recognize that nobody's focusing on them, nobody's staring, and nobody's pointing. Now, obviously, that exposure is difficult. I've had clients that haven't left the house in 5 years because of their appearance. And so once again, I'm not going to rush that. Sometimes just sitting in the office with me is the first non-family member they've sat across from, and it's building that trust and that confidence, and then starting to walk around my office and then across the street to a less populated area. But really, once again, is that the BDD is giving you messaging that there's something wrong with you. People see it as well, and that's one of the distortions, that other people see what you feel, and it's just not accurate.
Engage in self-compassion too. It's critical
Yeah.
and important for everyone doing treatment in different ways. 1227, I've been in treatment for a year now and making lots of progress. Advice for working on ERP and goals, but not overdoing it. Work-life balance, grad school, and not overworking. I love this question and I'll take it really quickly, but one of the things I talk a lot about is what I love to call ERP on the go. And ERP is a lifestyle. And I always tell people I'm not a runner. I don't like to run. So if you asked me to go run a mile with you, I wouldn't be able to do it. If you asked me to run a marathon, I would legit fail at it. But if Chris told me, like, Liz, I really want us to do a fundraiser and I want us to run a marathon, like, while I'd be like, Chris, you're nuts. I don't want to do this. But if I decided, fine, I'll do it for you because I love you and I'll make this happen, I would train and I would start doing things where, guess what, in a month or so, the mile wouldn't be so hard. And by the year when I'm ready to run the marathon and I've trained and I'm ready, like, not only could I run a marathon, but I might actually enjoy the mile, right? Like, I might have actually found some things I like about running and I might have actually made myself enjoy the activity overall. But certainly the thought of running a mile would not be as scary in a year if I've been practicing and I'm way past a mile than it is today. When you think about ERP, I want it to feel very similar, that it's this muscle we're working. And the more we engage in ERP, the more it just becomes a part of our lifestyle. And I am not a believer that when we're into ERP and we're doing well and our symptoms are being managed, like, I don't need to sit down and say, okay, I need to set aside 2 hours a day to do ERP, because guess what? Like, it's more important for me to spend 2 hours with my kid or going to do life or seeing my friends or grabbing coffee and things that are valuable and important to me. But I do ERP along the way. Right. When I'm at a coffee shop, there's tons of ERP that I'm doing around my previous contamination triggers. When I get ready in the morning, there's different, ERP that I'm doing, but I might not even recognize it as ERP anymore because it may not be triggering. And so what I want to encourage you is that if there's still active triggers or things that you know you're avoiding, yeah, you might need to set aside a little bit more time to do some specific ERP because you need to really hold yourself accountable. We don't want to suppress and avoid. But life in and of itself is a huge ERP science experiment, right? Like, we're doing ERP, we're focusing on that all the time. And so I just want to push us that, to me, it doesn't have to be this like overwhelming, dreadful, like, oh, I have to do my ERP today. And it's this like big homework assignment. Instead, it can just be a part of your lifestyle. And what you will find, Chris, tell me if you agree, is that the more you do it, it actually becomes kind of fun and it becomes a challenge. And it's something, because you're so proud of yourself, right? That like you were able to do that and that there was actually enjoyment and pleasure in it, that it isn't this scary thing. It's like, man, like, look how far I've come.
Yeah, I mean, I'll just add to that because you answered it so great. I think when you said that, it's like the way that I balanced life after treatment and got engaged is everything that Liz said. It wasn't like setting time aside. I just started living life. And did triggers come up? Sure, but I knew how to handle them. So, definitely work, grad school and stuff, make that the most focus, and you'll still have ERP goals in there that will pop up in real life.
Totally. All right, so I know we only have 5 minutes, so we're going to have to hop off in just a second. So let's try to get to some of the remaining questions. I know there's lots of different things. Suggestions for those struggling with romantic relationships when they start to come up during recovery. I've been avoiding them for most of my life. So thoughts, Chris, on, sorry, I'm going to hop to the next question first. What is false memory OCD? So this is when individuals, and you can see the town hall, you can click on that there, but this is when individuals are often, this is when individuals have a memory of something that may have actually happened, right? So like there may have been a real event or something that happened that now it's morphed. So OCD is latched onto it and we're having a hard time deciphering what's real, what isn't real. Oh, but there's a real event attached to this. So it feels more significant. It feels more real. Chris, sorry. Back to the other questions.
Why don't you answer that one? Because the next one I think I'll be good to answer.
Okay. So any suggestions to those struggling with romantic relationships when they come up in recovery? So and you've been avoiding them. Here's what I would say. If engaging in a romantic relationship is important in our life and it's something that we want to do, let's push it. And that in and of itself is recovery. That is how we move forward. These things that OCD has taken away from us that we might get kind of excited about, but we're nervous about, start living, start engaging in them, start having them. And what you're going to find is that, yeah, maybe you've been avoiding them for most of your life, but that doesn't mean we have to keep avoiding them. Instead, let's engage in them.
I'll handle the one at 12:36. Can you become gay? I'm worried that becoming gay at 20. I've loved women all my life throughout high school and middle school. I don't know what's happening to me. The reason I wanted to answer this question is because you already answered the question in can you become? That is very different. Can you become? What if I become? And that's not only solely for this subtype, it's for every subtype. What if I become sick? What if I hit somebody with my car? What if I end up liking my family member? That what if is the key to being OCD. Because if you ever interact with people that don't have OCD, it either is or it isn't, right? And so as somebody who is gay, there was never this point in my life that I'm like, what if I become? It's like the feelings, the sensations, like just it happened, my attraction. I mean, I grew up and never found women attractive. I always found men attractive. There was never this period of like doubt and back and forth. And so when I see clients with sexual orientation OCD, there's so much struggle. There's a need for certainty. There's doubt. There's trying to figure things out. There's compulsions. Nobody in the LGBTQ community has that same experience. For a lot of us, we're trying to figure it out. We know society doesn't accept us and kind of hates us for it. So there's a lot of hesitation for opening up and trying to be clear because we don't want, to go out there and, society to dislike us. But Joe, like that whole questioning, all that doubt, that's the OCD. And so what I would suggest is like not putting too much emphasis on the content because that's going to get you all confused and start to look at the mechanics. OCD is trying to tell you you're something. Instead of recognizing that as an obsession, you're treating it like it's a fact. And then you're going on this fact-finding mission through compulsions. And since compulsions equal confusion, you're less clear than when you started. Drop those compulsions, clarity will come through, and you'll have your eventual answer. And then I'll say, lastly, what we always say is, almost nothing in life is certain. You just, it's got to be a good enough answer and then choose to move on and re-engage with life. And if you like women, go date one. There's a lot out there. Oh, Liz, you're muted.
Well, there's that. Sorry, I'm trying to just see if there's any other questions that we should definitely get to today. I think a lot of it is questions, is responses to us. But what I can tell you is that this has been fun. It's been awesome. Thank you for engaging. There are so many questions and lots we didn't get to. What we will do is Skyla and us will compile these questions and we'll kind of see which ones we didn't get to and make sure that we pick up where we left off. Chris and I have also been committing, and we just haven't had time to do it yet, but we will, that we will record and get to a lot of these questions and be able to post that as well as a response, because it's important to us that we have this engaging conversation. But I just want to say thank you. I'll let Chris wrap up today, but I love engaging with you guys, and I love being able to share feedback, share perspective. You come with so many important questions, and what is evident is that you are all working so hard and you're wanting to know how to address and how to fight your OCD. And I want to make sure that we remind you that help and hope are available and that with the right treatment, you can achieve freedom. That's what we're fighting for. Freedom, not functioning. Chris?
Yeah, I just want to say thank you. We haven't been, because of the conference, because of Research Roundtable, I think this has been our first one in like a month. So we're super, super excited. We are always bummed when we don't get to all the questions, but Skyla, starting at 12:39 with Troy 5155 and on, we didn't get to those questions, but we have this list of all the questions. We're going to record some on our own. We'll get to them next time. So we won't be back with a Q&A next week. That's actually going to be the focus on perinatal OCD, same time next Wednesday. But the following Wednesday, we will be back with your Q&A. And we love answering these questions. We hope you find it helpful. And like I said, if your question didn't get answered, we definitely have it down. But I always want to thank the community for coming out. This live stream is only here because of the attendance, the questions, and the support you give us. So thank you so, so much. And come back next Wednesday. Hang with us.
100%. See y'all soon. Bye.
IOCDF.org.